Hi, my name is Dr. Carlos Wesley. I'm summarizing the lecture that I recently delivered at the International Society of Hair Restoration Surgery meeting in Chicago, Illinois in 2015. This is an update on a technique that I introduced about 2 years ago at the meeting in San Francisco called piloscopy. I'll explain it in more detail, but essentially it's an inverted version of FUE, follicular unit extraction, where we can come up from below and capture the stem cell containing portion of the hair follicle and leave the overlying skin surface intact. So it was about 7 years ago now, in 2008, when I first exchanged an apple pie with my old anatomy professor for the privilege of going into the cadaver lab and really testing out this theory. Since that time, and I've probably flown almost 300,000 miles between my office and the engineering firms in order to develop something that now is in a form that we can really start to use in the manner I had initially envisioned. Now, why would someone go to all this trouble? Well, piloscopy incorporates the benefits of the two current techniques that we use. On the donor side, there's no linear scar, and there doesn't appear to be any punctate scarring, the little white dots that patients oftentimes get from FUE because we're leaving the overlying skin surface intact. On the recipient side, since we're including that surrounding protective tissue, and I'll show you images of that, that's been something, when the grafts are then transplanted, that's been something that has been shown to increase survival rates. So in 2011, when I was just starting out with this concept and bootstrapping the whole idea, I needed to come up with a way, without sophisticated instrumentation, to simulate this approach. And so with IRB approval on 6 volunteer patients, what I did is I took a strip of scalp, inverted it, and used a simple coring cannula with a clipping component to take out the grafts and leave the overlying skin surface intact and then transplant them. We also did this with follicular unit extraction on each patient. Now on the left-hand side, here I'll show you with the mouse, on the left-hand side you can see the typical intraoperative appearance of FUE grafts. This is a 1.0 millimeter punch. And these yellow arrows here correspond to hair follicles that were taken with a beneath the skin surface approach, a piloscopic simulated approach. You can see on the right hand side the yellow arrows just point to hairs that are absent, but there's no evidence of trauma to the skin surface. The grafts themselves, unlike the typical denuded or skeletonized appearance of FUE grafts, the piloscopic test grafts were more robust. They included more protective tissue around them, and again, that's been shown through various studies to increase the survival rate of the transplanted grafts. And so what we did then is we compared the survival rates of 170 FUE grafts and piloscopic grafts over 16 months. It was a double-blind study, and what we found was not only was the survival rate of the piloscopic grafts as good as FUE grafts, but in our study it was statistically significantly greater. Now, this was a small study and it should be scrutinized for its small size, only 6 patients. Also, the survival rate of the FUE grafts did vary quite a bit from patient to patient. Those are two things that can be scrutinized, but it's consistent with a lot of other findings that other doctors have done when they're simply looking at the variable of including or excluding that protective tissue around the stem cell containing part of the hair follicle. Now, moving forward, the evolution of the piloscope has been pretty substantial over the years, where we started out with sort of a clunky instrument that required an endoscopic camera to see beneath the surface. You can see in 2011 this is the coring cannula that I was referring to with its big clipping fingers that would tear up the tissue. We certainly don't do anything like that anymore. We protect the surrounding tissue much better. It was almost a gun-shaped model at the time with an endoscope. We then tried the high-frequency ultrasound component, a 40 megahertz ultrasound. It really allowed us to see the hair follicles beneath the skin surface in somewhat real time, but this was just too cumbersome. It was too much for any doctor to want to handle. So over time, each iteration has allowed a more and more complex device to perform a very delicate procedure with the ease for the operator of almost playing a video game. So piloscopy involves making a 1.4 centimeter incision. We're going to make that smaller over time to about a 1 centimeter incision anywhere within the safe donor area. An instrument comes and dissects out the working cavity. The subdermal arm of the instrument is introduced into that working cavity, and then the operator, just by following the monitor, can adjust the orientation of the instrument to harvest grafts. They go through a saline filled tube into a storage vial. Once the harvest is complete, you take the instrument out, throw in a couple sutures, and you're all set. Now, this image was taken back in July of 2014 in a cadaver lab where 98 grafts were harvested with a 1.0 millimeter FUE punch on the right side, and on the left side, that same number of grafts taken with about the same density was harvested in the box that you can see, and you see the tiny port of entry up above. Now, through this single port of entry, we can access everything within the occipital, which is the back of the head, and then the parietal regions, which is just behind the ear. We can access all of that through a single port of entry that's about 1.4 centimeters, but again, we're going to make it about a centimeter in the future. So the instrument is now in a good working position. You can see on the right-hand side, there are two monitors. On the right-hand side, it's the monitor that shows us how the little hairs exits the skin surface. And in the center, that monitor shows us what the grafts look like when they come into the storage vial. So we can see each one and make real-time adjustments. Now here we're going for graft at 5 o'clock. Come up from below and take it, leaving the overlying skin surface intact. Now we're coming for the graft at 7 o'clock, coming up from below and taking it, and again leaving the overlying skin surface intact. It's almost like doctors performing FUE, but instead of punching right over the graft, you're extrapolating. We're going for the one at 7 o'clock here. We just took it, leaving the overlying skin surface intact. We can come within about a quarter of a millimeter, and that's up to the operator to really adjust the instrumentation accordingly. The grafts themselves, again, these are all taken on cadavers. Throughout the course of the year, every month and a half or so, we test each iteration of the device on a cadaver to make sure that it's functioning the way we want it to. The grafts themselves, we're including the surrounding protective tissue, which is great, but the big challenge has been orienting, being able to get the proper angle. And I know there's been a lot of frustration with how long it takes, but that's the real holdup, is making sure that we can optimize the angle. Here you can see when the angle's on, the grafts are healthy, but when we go to a new region and the angle's off a bit, we have to make another adjustment, and then we're getting healthy grafts again. Grafts themselves on cadavers are especially tough because they're in what's called the telogen phase, so they're really short, about 2 millimeters. Live humans have hair follicles that are about 4.2 millimeters deep. The grafts that we harvest can either exclude or include that little tiny hair shaft at the end of the graft, and when you include it, based on how close you bring the clipping fingers together, if you leave a little space, you'll include that. That will help with the planting of the graft, so we see how they curl. But if you bring the clipping edges all the way together, then it cleaves off that last little hair segment, and that can be advantageous if we do find that there's a good amount of donor regeneration, and if we cleave that off, that leaves that overlying hair follicle intact in the donor area, and that can help enhance any regeneration. So now we've started on humans. There are actually a couple patients in 2014, in July of 2014, that underwent the procedure. At that time, I realized that we did need to further optimize the angle of the instrument, the ability to angulate. It was safe, it was comfortable. A couple of things that we learned, though, that were very helpful from 2014's live human trials. You can see up here, this is the donor area taken in 2014. Here it's 1 year later. All of this has been undermined and all of this has been harvested. And you can see that the only areas down here that show that punctate scarring, those little white dots, are areas where we accidentally went through with the instrument. We punched through the surface of the skin. You don't see that anywhere else. And this was a concern of mine and something that a lot of doctors raised, that what if we still see those white dots if we're coming close and leaving the overlying skin surface intact, because little cells called melanocytes may be lost? Well, it doesn't seem to be the case, first of all, but also in theory, melanocytes in humans are not restricted to hair follicles, but they're present in and around in the epidermis and dermis surrounding those areas. And also, something called epidermal melanogenesis is separate and independent from the hair follicle cycle. So that means if we're taking a hair follicle, removing it, leaving the overlying surface, the epidermis, intact, melanogenesis, the generation of this pigmentation, is still going to continue. So that's something that was a really important finding, something that was very reassuring, and we'll hopefully see that in the future. Now, I admire the work of these physicians in Spain, they did a special study with a marker, immunohistochemical marker called CK15. And what that does is it lights up in the stem cell containing bulge region of the hair follicle, sort of the top colony of stem cells in the follicle. So we sent our grafts off to Spain, and they showed us two things. One, that the grafts that we're sending do not include the infundibulum, and that's the very top portion, that's the skin surface of the graft. So these aren't the punched through grafts, these aren't the ones that were taken all the way through, but rather these are the grafts where we clipped it off and left the overlying skin surface intact. So one, they did not include the skin surface, and two, they stained as CK15 positive. That was great because that showed us that we're getting the stem cells that are sort of the top layer. So if we're coming from below, we're getting everything in the bottom part of the hair follicle, the bulge, and we're going high enough to get everything in the top part of the layer, the bulb on the bottom and the bulge on the top part of the layer. Those are the two colonies that are essential for survival of the hair follicle when it's transplanted and in the future. Now we have started doing a small number of clinical trials in 2015. We'll start to do more and more as we see that it's working the way that we want to. 4 patients. I'm only doing about 5 grafts at a time at this stage. And I'm starting to get the hang. It's taken some practice, but I'm starting to get the hang of the angle and direction. You can see here on the right-hand side, I'm a little bit off on my angle, and the hair follicle is actually this direction. I'm coming up in this way, so it's not a perfect graft. But it is the type of thing that takes some practice, just like any doctor when they're starting with FUE. They always start with a few small cases, and then they get more and more proficient and do larger cases and become a little bit faster with it. What I can tell you is we'll learn a lot over the next year as we start doing larger and larger cases. One of the things that I can glean early on is patient feedback. Of these patients that have experienced it, they've reported that the tenderness is, so I'll explain what this is. This is sort of a triangle depicting where we've undermined the area where we're working in the scalp. This is where we enter, this is where we undermine, and these little marks are the sutures, because I'm giving patients early on some free grafts when I take a little strip, and that's how they get their free grafts with the traditional strip harvest. What they have described is there's really little difference in terms of tenderness where it's been undermined versus where nothing's been touched at all. So that was very reassuring. The only discomfort really is where the sutures are, where they're just simply getting free grafts for these experimental phases. So down the road, it's really these numbers that are important, because this is all it will involve. It's not going to involve the strip harvest when we start doing pure piloscopic sessions. A couple important things that we have not seen, which is very reassuring. There's no shock loss in the donor area where we've undermined it. There don't seem to be any hematomas. We use a compressive bandage. We put a sort of a tight bandage on for the first 12 to 14 hours so patients don't have swelling back there. There haven't been any infections or anything like that. So so far everything has been good, but I'm starting very conservatively and doing things very slowly, just because I want to make sure everything works exactly as intended before we start ramping up to larger and larger cases. So in summary, why is it worth it? Well, in addition to the benefits that I just discussed with the donor and recipient area, one of the really exciting things is patients may not have to shave their head at all in order to have this procedure, since we're coming from beneath the skin surface. It'll be a much faster procedure because grafts don't need to be altered at all. They can go right back in because we always cleave off that skin surface before transplanting them, and that's already something that's done when these grafts are generated. And lastly, and this is important for young patients, sometimes when we're harvesting grafts, we inadvertently go outside what's known as the safe donor area, the SDA, the area where the hair is permanent. So if we inadvertently go beyond that when we're harvesting and patients ultimately lose the hair around it over the next 20, 30 years, with this approach you're not going to have that stigma of a white dot, that punctate scar when everything is exposed over time. So that's something else that's a real benefit. And we're excited to see all the different possibilities as time goes on. Okay, thank you for your time.